The elbow. By the end of this PowerPoint, you'll know how to take an elbow x-ray, label anatomy on the elbow, and understand the eval criteria and what makes a good image of the elbow. An AP elbow. The patient will be seated near the end of the table, low enough so the shoulder joint, humerus, and elbow are all in the same plane. Extend the elbow and center it to the IR. The IR should be parallel with the long axis of the elbow. The patient will lean laterally until the humeral epicondyles are parallel with the IR. Your SID will be 40 inches. Your central ray will be perpendicular to the elbow joint. Your collimation will be 3 inches proximal and distal to the elbow joint and 1 inch on each side. Mark on the lateral side. Tell the patient to hold still and not to move. Anatomy of the AP elbow. This is the humerus, the ulna, and the radius. The radial tuberosity, the radial neck, the radial head, the cap, the lateral epicondyle, and the medial one. So what makes a good image of the AP elbow? There should be proper collimation and a marker. The radial head, neck, and tuberosity slightly over in the proximal ulna. The elbow joint centered to the exposure field. Open humeral radial joint, no rotation, and the bony trabecular detail and surrounding soft tissue. This image on the left side has open joint space, it's slightly superimposed. You can see the soft tissue and there's minimal rotation. There is a marker. The image on the right needs a marker, however, everything else is good. This is some examples of a poor AP elbow. The technique factors is making it hard to see all the bony details. There is a little bit of an open joint space and they do have a marker, however, it is over the soft tissue. This one looks rotated and the arm isn't all in the same plane. A lateral elbow. This is done lateral-medial. The patient will be seated at the end of the x-ray table, low enough so the shoulder joint, humerus, and elbow are all in the same plane. You will then get the patient to flex the elbow 90 degrees and place the humerus and forearm in contact with the table. To obtain a lateral projection of the elbow, adjust the hand and wrist into a lateral position to ensure that the humeral epicondyles are perpendicular to the IR. Your SID will be 40 inches. Your central ray will be perpendicular to the elbow joint. Your radiation field should be 3 inches proximal and distal to the elbow joint, 1 inch on each side. You're going to mark on the lateral side. Tell the patient to hold still and not to move. Anatomy of the lateral elbow. You have the humerus, the radius, and the ulna. You have your anterior fat pads, your humeral epicondyles. So what makes a good lateral elbow? Evidence of proper collimation and a marker. Elbow is centered. The elbow is in true lateral, meaning the humeral epicondyles are superimposed. The radial tuberosity is facing anteriorly. The radial head partially superimposing the coronoid process, and the abracon process is in profile. The elbow is flexed 90 degrees. You'll see your bony details, your elevated fat pads, and soft tissue. So for this image on the left, it has a marker. It is flexed 90 degrees. There is a slight superimposition, and you can see your fat pads. The image on the right, it did have a marker, but it did have to be cropped out. Everything is flexed. You can see your soft tissue, slightly superimposed. You can see your fat pads. A poor image of a lateral elbow. So this one on the left needs to be collimated. They also clipped soft tissue, which would make it be repeated. The image on the right is flexed more than 90 degrees, and the epicondyles are not superimposed. AP oblique elbow, lateral rotation. The patient will be seated at the end of the table, low enough so the shoulder joint, humerus, and elbow are all in the same plane. You're going to extend the patient's arm and rotate it laterally, externally, to place the posterior surface of the elbow at a 45-degree angle. When proper lateral rotation is achieved, the patient's first and second digits touch the table. Your SID will be 40 inches. Your central ray will be perpendicular to the elbow joint. Your collimation will remain the same for 3 inches proximal and distal to the elbow joint and 1 inch on each side. Mark on the lateral side. Tell the patient to hold still and not to move. Anatomy of the AP oblique elbow with lateral rotation. You'll have your humerus, your ulna, and your radius, your radial tuberosity, your radial neck, and your radial head, and your cap. Some high-quality images of an AP elbow with lateral rotation. You'll have proper collimation and a marker. You'll have the elbow in the center of the exposure field. You'll have a 45-degree lateral rotation, and this can be shown by the radial head, neck, and tuberosity projected free of the ulna. You'll have an elongated lateral humeral epicondyle, and you'll be able to see your bony detail and the surrounding soft tissue. So this one on the left, you can see the space between the radius and the ulna. It has a marker, and you can see your soft tissue. This one right here on the right, you cannot see the soft tissue. But other than that, it is good. It has a marker, some joint space right there. So some poor quality images. This one on the left, you need to open the collimation because you need more of the humerus, and they're centered way too low. It does have some open joint space, and you can see your soft tissue, and it has a marker. That's all good. The one on the right, they overexposed it. It's hard to see all the bony detail. However, they did have a marker, and you could see the soft tissue. The radius and ulna are still on top of each other, so the patient was not rotated properly. AP oblique elbow medial rotation. You're going to keep everything the same as the lateral one, except you're going to medially rotate the hand to place the humeral epicondyles 45 degrees from true AP position. The hand may be pronated or at a 45-degree angle. Anatomy of an AP oblique elbow with medial rotation. You will have your humerus, your ulna, and your radius. You will have your medial epicondyle. You will have your coronoid process. You will have your trochlea, your O-word process, and the fosfa. Some high-quality images of an AP elbow with medial rotation. You'll have proper collimation and a marker. The elbow will be centered. A 45-degree medial rotation of the elbow. The coronoid process and profile, elongated medial humeral epicondyle, and the ulna will be superimposed by the radial head and neck. You will have your trochlea and your olecranon process within the olecranon fosfa, and you'll be able to see bony detail and soft tissue. So this one on the left, you have your ulna and radius overlapped. You can see your process and your fosfa. You can see all your soft tissue. This one is missing a marker. This one on the right, also missing a marker. However, everything else is good. Some poor quality images. So this one on the left, you cannot see your process or the fosfa because it is overexposed. The one on the right, the ulna and radius are more lateral than just a slight overlap. However, everything else is good. AP elbow partial flexion. This is done when a patient cannot completely extend their elbow to obtain an AP projection. Therefore, there will be two separate AP projections, one of the distal humerus and one of the proximal forearm. For the distal humerus, the patient will be seated at the end of the table. If possible, you will supinate the hand and place the IR under the elbow, centered to the condyle area of the humerus. The central ray will be perpendicular to the humerus, transversing the elbow joint. Depending on the degree of flexion, you may need to angle the central ray directly into the joint. For both projections, there will be a 40 SID. You will tell the patient to hold still and not move, and collimations will be 3 inches proximal and distal to the elbow and 1 inch on each side. You want to mark on the lateral side. For the proximal forearm, you will have the patient still seated, but you are going to center to the elbow joint and the long axis of the forearm. Anatomy of the AP partial flexion elbow. So this first image is the distal humerus. So the humerus is going to be better seen. However, you can still see all the little things of the ulna and radius. You will see your medial and lateral epicondyles. You will see your cap and your trochlea. On the proximal forearm, you will see the humerus, but it's going to look weird. You're going to see your ulna and your radius, your radial tubercle or tuberosity, your radial head, your cap, and your trochlea. So a high quality image of an AP elbow partial flexion. Both of them you want proper collimation and a marker. You want the distal humerus or proximal radius and ulna without rotation or distortion, and you want all the soft tissue and bony detail. Over here for the distal humerus, you want the proximal radius superimposed over the elbow, over the ulna. You want a closed elbow joint like this, and you want a greatly foreshortened proximal forearm. For the proximal forearm, you want the radial head, neck, and tuberosity slightly superimposed over the proximal ulna, like this. You want a partially opened elbow joint, slightly opened, and you want a foreshortened humerus. Poor quality images. So over here, it says distal humerus. There's no marker. In my opinion, this looks like there's a motion right here, and right here that might just be it broken. Unsure. There is an open joint space, which isn't supposed to be open, and there is barely any soft tissue. For the proximal forearm, they are overexposed. You cannot see any of the detail in the humerus or the elbow joint. There's too much superimposition, and this elbow joint is very open. Axiolateral projection, the coil method. This is for the radial head and coronoid process. You're going to have the patient seated at the end of the table or laying down supine. You're going to slowly pronate the hand and flex the elbow 90 degrees to show the radial head or 80 degrees to show the coronoid process. The epicondyles should be perpendicular to the IR. The central ray will depend on whether you're going to be demonstrating the radial head or the coronoid process. For the radial head, you're going to direct the central ray 45 degrees towards the shoulder, or for seating, or 45 degrees cephalad if the patient is laying down to enter the middle joint. For the coronoid process, you're going to direct the central ray 45 degrees away from the shoulder if the patient is seated, or 45 degrees caudal if the patient is supine, entering the middle of the elbow. You will have your patient SID 40 inches. Your collimation will be 3 inches proximal and distal to the elbow joint and 1 inch on each side. You will mark on the lateral side, and you will tell your patient to hold still and not to move. Anatomy of the axiolateral projection coil method. Over here we have the radial head. So you will see the humerus, the radius, the ulna, all the details on the radius, and your cap. Over here is for the coronoid process. You will see the humerus, the radius, and the ulna, and your trochlea. Alright, so for a good coil method image, both will have proper collimation and a marker, and bony detail. For the radial head, you'll have an open joint space between the radial head and your cap, right there. You'll have the radial head, neck, and tuberosity in profile and free of superimposition, right there in your head. Your humeral epicondyles will be distorted due to the central ray angulation, and the radial tuberosity is facing posteriorly, right there, and the elbow is flexed 90 degrees. For the coronoid process, you will have open joint space. The coronoid process in profile and elongated, right there. Your radial head and neck is going to be superimposed by the ulna, there, and the elbow is flexed 80 degrees. Alright, so some poor images. This one is to see the radial head. You're clipping soft tissue. It is overexposed. The joint space is closed, but it is hard to see any detail. This one is to see the coronoid process, which you cannot see. It is way over flexed. It's only supposed to be flexed 80. It is superimposed right there, but there is an open joint space. All right, question 1. Which anatomy structure is best visualized in a 45-degree medial oblique projection of the elbow? That will be C, the coronoid process and profile. Question 2. Which structure lies directly distal to the trochlea of the humerus? The correct answer is B, the coronoid process. All right, last question. Question 3. Which positioning characteristic best indicates that the humerus is properly positioned for the AP projection of the elbow? The correct answer is C. The humeral epicondyles are parallel with the IR. My list of references.